Thank you, Senator Smith. Senator Cassidy.
Thank you, Madam Chair. Gentlemen, and lady, I'm sorry. I've got a bunch of questions, so if I hustle you along, it's not to be rude. Obviously, I'm very interested in this topic. I have on my website, I have a Making Healthcare Affordable Again, and one of the things we address is administrative cost. Now, some of this, I have to admit, there's kind of cognitive dissonance. Dr. Cutler, you mentioned how kind of ascribing to the federal government the role of making things less administratively burdensome, and I'm thinking, man, I must be dropping acid. Not that I've ever dropped acid, but for the record, I have not. But in one of the briefings we were given, the American Hospital Association has a report, Regulatory Overload, 629 different regulatory requirements from 4 different federal agencies. Mm-hmm. I'm sure Mr. Isles could give me the same thing for insurance. Having practiced medicine, it is incredible how much the federal government loads upon us. And I almost, my jaw dropped when you said most providers are pleased about the electronic health record. Mm-hmm. Actually, I read the leading cause of burnout for physicians is the electronic health record. So I'm not sure who is finding it so, who's so enamored, because the electronic health record is just so burdensome. Mm-hmm. Somebody was put in their testimony 30 minutes of clicking for every 5 minutes of seeing a patient. They said 30-30. I find it's 30 minutes of clicking for every 5 minutes of seeing a patient. It is just a parallel reality if we're going to say that patients, that docs are enthralled with this. Mm-hmm. And I say that not to chide or to confront, but just to observe. Dr. Book, I like your perspective. We've not looked at the administrative burden upon the patient or the physician. We've looked upon it on the system. Yes, the physician some, but not nearly as much. One model we talk about in our white paper is the direct primary care model, in which a patient pays a monthly fee, and the doc does not bill insurance companies for those services covered by the monthly fee, and the patient doesn't have otherwise a deductible or copay, co-insurance. Rather, it's just that monthly fee. Senator Cantwell and I have a bill that would promote this. Any thoughts about direct primary care? Are you familiar with that?
I'm not familiar with it before, but it sounds like it has potential. I think the question I'd want to know is, will that act as what percentage of the healthcare system will be affected by that? That could be obviously effective for a large percentage of patients, but the large dollars are going into very sick patients needing specialty care.
So you mentioned that, and so the way it works is that you would still have a catastrophic coverage on top. It started in Washington State, hence Senator Cantwell's interest. But for that kind of ambulatory service, I have a headache on Friday afternoon. I don't go to the ER. Rather, I go see the doc with whom I have a contract. Right. That seems to work for both the patient and the doc. It keeps them out of the ER.
Like I said, that sounds like it has potential. I'd be happy to look at it and answer and say something for the record, write something for the record later if you'd like. Got
you. Dr. Cutler, you had mentioned the issue with prior authorization and how Medicare doesn't have prior authorization, but Medicare has an ungodly amount of waste, fraud, and abuse. Go down to South Miami and there's mansions built upon waste, fraud, and abuse from Medicare. So there is that tension of the prior auth with the absence of it at Medicare, yes, but a lot of, now I like your concept, could we standardize? But Mr. Isles, for you to suggest it's not a burdensome upon the patient, when I would see, upon the doc, when I would see patients, my nurse would just put the phone on speaker as she heard over and over again, your call is very important to us, please hang on. And 45 minutes later, that very important call would get answered, and yes, it would be then approved. Frankly, docs perceive that prior auth is used merely as an obstacle by which they will not prescribe a certain therapy, even if it's indicated, just to say that. Why could this not be integrated into the electronic medical record? Why does my nurse have to be on the phone as opposed to the insurance company just being able to otherwise access?
Well, I think the challenge right now, Senator Cassidy, is really around interoperability of electronic medical records.
Now, I thought, though, Humana gets all my billing data. for example, because when I toured their MA plan, they truly do download all my billing data.
And
so
that
why
may
don't
be-
they use that?
Well, then that may be for some plans, and it may not be for all electronic medical record systems, right? I think that may be a good example of something that we can learn from in terms of how we could scale that and apply that more broadly. But
Okay,
right
then
now,
let me stop you. Dr. Cutler, you had mentioned that there is increased overhead associated with private plans, and yet what I've read is that in countries such as the Netherlands, which only use private plans, they still have half of our administrative overhead. So it doesn't seem inherent that it's going to be the federal government, because as Dr. Book convincingly tells me, the overhead associated with Medicare is actually more costly than in private plans. There's something the Netherlands does, though, that is different. Any comments on that?
Yes, in most countries, the Netherlands is an example, Germany is another example, where they have competing private plans. The private plans are highly regulated, so they don't impose, for example, pre-authorization requirements.
So it kind of goes back to the standardization of
It
what
goes
you would
back
do.
to standardization and to, they don't have all the different severity codes and all of that, so they've eliminated a lot of the administrative
Gotcha.
costs.
And so two more things about that. Mr. Isles, I've heard of something called a real-time benefit analysis. Going to the interchange between Senator Murray and Dr. Cutler, the patient doesn't know how much something costs. By the way, I will note these horror stories are under Obamacare policies, not under limited programs. But that said, a real-time benefit analysis where you can press a button and the patient automatically knows how much they owe relative to their coinsurance and copay. I'm told some insurers have this, have not just yet implemented. Why would this not be more broadly available?
well, most of these tools are available through our members. The vast majority, well over 80% of them, have these types of tools. The question is, are they being used at the point at which care
I
is
was
being
told
delivered?
specifically they've not yet been deployed, in the sense that when I go to my MRI, that I can click and it says, on my coinsurance deductible, I have $200 left to pay. Dr. Cutler, you're nodding your head. Are you familiar with which I speak of?
Yes, in fact, that is true. A number of them have, some of the plans do not have it. A number have it, and either they don't make it available, or it's only available in very difficult to access circumstances.
Yeah, it seems like we need to make an app for that, right? Dr. Book?
Yeah, and I can tell you from my personal experience that sometimes they get it wrong. There was a provider who told me I still had some left on my deductible when I'd actually fulfilled my entire out-of-pocket limit for the year. So the information they get is not always correct.
So it
I'm
needs,
not sure why
it's
that
still
is.
beta version, but it's they're in concept.
Well, no, it's a great concept, and it works. It seems to work at the pharmacy, but it doesn't seem to work anywhere else.
I am way over. I thank you, Madam Chair, for your indulgence. I actually have one or two more, but I'll let it go.
I think we'll have an opportunity for second round real quick. Senator Warren.
Hey, thank you, Senator Scott. I just can't help but, in all due respect to Senator Warren, comment on a couple things. Dr. Book, your analysis has total credibility with me. And I'll say it because the first time I saw that the DOJ was doing a major anti-fraud thing on all the ripoff in South Florida and Louisiana on Medicare, and I realized that Blue Cross would have done that on their own ticket. And instead, it is the there's the DOJ doing it for CMS, made me realize that that was not being included as part of it. As regards the Medicare for All, again, I can't help but mention that the Urban Institute, pretty liberal, Mercatus, as well as the Tax Policy Center have all come in with numbers roughly the same, roughly that we would, it's just quite remarkable. Medicare for All under conservative estimates would increase federal budget commitments by approximately $32.6 trillion in the first 10 years of full implementation. Would have to double corporate and individual taxes. It still would not be enough to pay for everything. So just to say that there has to be a little bit note of reality as opposed to wishful thinking in all this. Now back to the questions I had kind of on my own. Mr. Isles, major part, and Ms. Holtberg, a major part of the administrative overhead associated with all of this is negotiating prices. Somebody pointed out to me that Medigap policies proliferate. Even on the Obamacare individual markets, they are very limited. And partly is that Medigap policies are able to piggyback on to Medicare pricing. All that effort to negotiate has been done, to Dr. Cutler's point, and so you can just say, I'm going to pay you Medicare pricing, and then the insurance company can come in and immediately has a provider panel. Now, Mr. Isles, what would you think if, say, on the individual exchanges in a state where you only have one or two insurance companies, like Louisiana, effectively a monopoly, you could say, okay, we're going to allow insurers to come in and to use Medicare pricing or a multiple, 1.2, 1.3 times Medicare pricing, and they're immediately in business to provide competition to the stakeholders. Why is it important? It's clearly been shown when you have only one or two dominant insurers, costs go up. If you have more competition, cost goes down. And that may get after what Dr. Cutler says in these countries like the Netherlands, one of the ways I'm sure they regulate is by pricing. I see his nodding his head. First, as a provider, Ms. Hultberg, what would you think of that?
So I'm going to defer a detailed answer on that to the insurance colleague next to me. I will note a couple of things, though, with respect to Medicare. First of all, Medicare does not cover costs in my state. So as we talk about
So it could be a multiple.
And a multiple is fair, and there are insurance companies currently who are basing pricing off a multiple of Medicare. So, but I do think that as we have this conversation, whether it's Medicare for all or some other variation of Medicare pricing, it's really important to note that often Medicare does not cover costs, and in my state, it is pretty generally speaking.
I can't help but say that under Graham Cassidy, the amendment that we had put up, Medicaid in Alaska would have had their true costs recognized. For some reason, your governor strongly opposed having his true costs recognized, but that's up to him. Mr. Isles?
I mean, let me just start by saying we support having access to choice and competition within the marketplace, and we think that's really important. I think right now the knowledge about the Medicare fee schedule, about what Medicaid is paying, is available out there. I think we want to make sure that plans are negotiating with physicians in the most effective way, that we're moving the system towards paying for value, not just looking at what Medicaid or Medicare might be paying. So, I mean, there's...
Well, let me interrupt, because the problem is all that requires a heck of a lot of negotiating and putting together a provider panel, and right now we have whole counties in Iowa that don't have a single insurer. So I don't want the best to be the enemy of the adequate. Dr. Book, any thoughts upon what I just offered?
Yes, sir. I think it's interesting to note how Medicare makes its prices. They do not negotiate with providers. They just set prices by regulation.
But they do look at cost reports.
They look at cost reports, and they also, for physician services, they survey about 100 physicians for each code they're reviewing and ask them to evaluate the service they're reviewing compared to some other service and answer a few questions on a multiple choice 5-part scale, whether it's about the same or more difficult or less difficult.
But the physician doesn't have to take Medicare. And granted, there's some places where they take less Medicare, and you could pay a multiple. But the point is, we got a problem.
An insurance company can choose to pay a multiple.
We have concentration among
patient.
insurance companies, and they can set rates to physicians and to other providers, and we don't have the insurer. I guess I'm looking for a solution. Dr. Cutler, any comments on this?
Yes, so I think getting more firms into insurance and more competition is clearly very good and beneficial, and I think anything we can do to make it easy. I don't know. My sense is that that's less of an issue than some other things are, but let me not state that so assertively. I do think that we ought to be moving Medicare payments away from just the fee-for-service levels.
So I get that totally. I'm not saying that.
Right. So I think one would want to think about some kind of transition that says, here are the rates you have access to now, and then here's how we're going to move it over time.
Okay. Mr. Isles, last question. CalPERS has used reference pricing very effectively to lower expenses. And just for context, they do a survey of providers. They find the range for a hip replacement or a knee replacement is $20,000 to $50,000. Quality is equal, so they say to their beneficiaries, we'll give you $20K. If you want to go someplace else, you pay the delta, but in the meantime, we're going to give you $20K, and that's all we're going to pay. Turns out everybody lowers their prices, and we end up paying the same across the board. Seems to have worked. Can we use more of that? It's effectively price transparency, but brought into relevance to the patient, which sometimes there's an issue of bringing it into relevance. What are your thoughts about insurance companies using that more? And I'll open that up to the other panel, if y'all can answer quickly, because we're all over time.
Thanks, Senator Cassidy. I mean, I think there is interest in looking at innovative pricing models to make sure that we're getting the most value. I think the question really will come down to things like participation in networks, and will you have access to an adequate range of providers, and can you make it work for the patient, and do they have real-time transparency? There's a lot of considerations to think about, but I think anything that provides greater transparency to the patient and understanding about what the difference is between quality is a good thing. So I think there's interest in those kinds of activities.
Anybody else for a quick answer?
Senator, I'd like to just add that I think in the situation of California, you're dealing with a very large market, both of covered lives and of providers. And as we have this conversation, what we can't forget is the safety net providers that are like hospitals, open 24 hours a day. We need to make sure that as we look at things like competition and price transparency, that we're also addressing our safety net and ensuring that we don't lose our safety net.
Senator, if I could just offer one comment, which is the reference pricing has been a huge success. It's been a great success there. What they do is very intensive. So they call up the patient and they say, hey, look, you're scheduled for elective hip replacement. If you go to this institution where it's scheduled at, it's $60,000. The other one is $20,000. So therefore, you're going to pay the $40,000. If you don't do that, if you just say, look, there's a high deductible policy and so on, then people don't switch where they go. And it goes back to what we were talking about, what Senator Murray was asking about earlier. People don't understand the insurance policies at all, so they actually do very little price shopping. In a typical high deductible policy, there's essentially zero price shopping. It's when it's much more intensive that I go to you and say, Mr. Cutler, you can either pay $40,000 or pay your standard $200, and I can show you the quality metrics. Which one would you like? Then you can get people to switch. So unfortunately, it works well, but it's not as easy as we would like it to be.
And Dr. Book?
I think what Dr. Cutler is saying is there are administrative costs to implementing something like that, and in some cases, those administrative costs might be well worth it. We tend to think of administrative costs as waste, but sometimes those administrative costs are spent on very useful things, and that's an example of it, where you're calling someone up and explaining the situation, something they might not be able to look up themselves because providers are usually not posting prices in advance.
Okay.
So make more of it information available is costly, but it may be well worth it.
In our white paper, we advocate making that the providers post in advance, but I'll leave that to.
So that would be good, yes.
Madam Chair, thank you, and Senator Scott, thank you.
Least I can do.